Okay, for the second half of the lecture here, for the first week, we need to talk about physiology and psychology of pain. You can see the basic objectives here. I won't talk about them in depth. So what is pain? P exclamation point is a medical shorthand for pain. Pain is, as the International Association for the Study of Pain, defined as an unpleasant sensory or emotional experience associated with actual or potential tissue damage or described in such terms of damage. Notice it is sensory and emotional with actual or potential tissue damage. You'll see a lot of athletes, patients, right, with injuries that really aren't injuries because they have the potential damage, right? They get hurt, but they're really not hurt. It's that potential pain that they're waiting for. Like if you, I don't know, hit your toe off of the doorway or a desk, and you think it's going to hurt, you may even say ow, but it really doesn't hurt. That is what pain is. It's an unpleasant sensory and emotional experience with definitely has actual damage, or the potential tissue damage. So as an individual, highly variable experience, and pain is very, very variable and is affected by mood, culture, past experiences, as well as age and personality. So how can we gauge someone's pain level? Well, there's scales out there. The numeric pain rating scale is one of them. The visual analog scale is out there as well. If you've ever been to the emergency department in a hospital and they have the pictures up of the smiley face emoji all the way down to the frowny face crying, that's a pain level, right? It's a highly individualized experience based upon your mood. If you're depressed or an angry mood, you are going to experience pain more. Your culture. Some cultures never want to say that they experience pain or show that they experience pain. Past experiences, definitely. If you've been in a major trauma accident or experienced a major trauma, you will have a skewed view on pain, right? How can we tell somebody is tougher than someone else? Well, it's all pain scale, right? And you don't really tell if somebody is tougher than someone else. I'll say it right now. Females are tougher, if you will, than males compared to males. Males actually do have a shorter, if you want to say, tolerance for pain compared to females. From what we know up to now clinically, how can we measure this? Well, you haven't probably seen the visual analog scale or numeric pain rating scale. So when you're evaluating a patient and you ask them questions, what is your pain like right now? On a 0 to 10 scale, can you tell me what your pain is? 0 being I'm perfectly fine. 10 means take me to the hospital now, I'm dying. Well, most patients will be really, really say higher than they really are. They may say a 7 for a grade 1 ankle sprain, but then you may have another patient that has a tib-fib sticking through their skin and say they're in a 7. So it is very subjective, very variable experience based upon that person. So pain is the unpleasant sensation that must be interpreted by higher brain centers as pain. Nociception is the neural process of encoding and processing noxious stimuli. It's the neurophysiological process that may be interpreted as pain. Pain and nociception are different. So pain is an unpleasant sensation. Nociception is the neural process encoding and processing this noxious stimuli. Dimensions of pain perception. So you have your cerebral cortex. Your cerebral cortex is responsible for altering the perception reaction to pain. There are people out there that actually enjoy pain. They want to be in pain. Pain perception varies from person to person and even daily in the same person. Battlefield conditions. So this is something I get kind of caught up on. I get kind of angry at times when you watch like the NFL and on like say watch Monday Night Football and the announcers out there saying, "Oh, it's a war down there. It's just like a battlefield. Their athlete, that football guy, is going to war for his team." I hate that because I think it's disgraceful to those who've actually served in the military, who have actually been to real battlefield, real war. You cannot, in my eyes, compare a NFL football game, baseball game, whatever it might be, to a soldier at war. So I get kind of annoyed by that. But battlefield conditions is an athlete in the heat of competition may have altered pain perception versus out of competition. That's pretty common. Athlete gets hurt during the middle of a championship, like say the Super Bowl. They don't want to come out. They know that this might be the only Super Bowl they're in. They're playing for the national world championship, whatever it might be. They want to stay in the game no matter what, versus out of competition. It might be the off season. It might be right now in late June. They're doing training camp stuff, and well, maybe they want to sit out then. It is actually very difficult to convince a patient at times that yes, you're going to do more harm to yourself if you continue playing in this game, especially with the type of injury they may have. So that's what I mean by battlefield conditions. The dimensions of pain perception, you have sensory, which is very localized to the source, the area, and the type of pain. You have cognitive perception of pain, which interprets sensations based on past experiences and expected outcomes, right? Say you've been hit by a pitch before in baseball or softball, and it hurt. Every time you go up to bat and you get hit, you expect that it's going to hurt, even though it actually may not hurt. When I was 12, I played baseball growing up when I was 12 years old. I threw a pitch during practice, and the kid hit a line drive right back, hit me square in the forehead. And I woke up on the bench. I mean, I was 12 years old, and we didn't have an AT in Little League. But ever since then, at the end of my throwing motion, I have a little flinch. Still have it to this day. If I were to go play adult league baseball somewhere, I can't get rid of that because of my past experience of being knocked out and not being able to get my glove up fast enough. Interestingly, affective perception of pain influenced by the limbic system, it affects internal and outward response to stimuli. Internal perceptions, fear, anxiety, an outward response to that, anxiety attack even, right? So I hate flying. I'll use that as an example. I fly a lot though, and as I've gotten older and fly more and more, I realize things I need to do to make sure I don't get, anxiety built up in me because being on the plane. I read a book. I sit near the front of the plane. I'll take motion sickness medicine. I have different mechanisms for that fear, anxiety, if you will, for when I fly. Many patients, though, will have anxiety attacks. I think anxiety is just one of those things that is, I don't know, creeping up everywhere. I'm not sure why. And that outward response to that anxiety and fear, crying, that would be an outward response. But what is that patient's response to that internal pressure, perception of pain? I've had patients tear their ACLs and screaming and crying, "You can't touch them," to the patient who tore their ACL. And I asked what happened, how they felt, and they said it was a funny kind of pain. It kind of tickled in their knee. So you'll have the gamut. With pain threshold and pain tolerance, there are two different terms here. Pain threshold is the level of noxious stimuli required to alert the individual to a potential threat to tissue. A delta fibers, remember those from last lecture, carry the painful info. How can we recreate this in the clinic with a patient? Well, we can actually use a TENS unit, IFC, interferential current, an electrical modality to stimulate the A delta fibers on like a burst mode to carry that painful info. But we're not really carrying painful info, we're carrying electrical impulses that override that painful info, if you will. It's pain threshold. Pain tolerance, how much of pain a person can or will withstand. Two separate things. So the pain threshold, the amount of pain or noxious stimuli, I should say, required to alert the individual to a threat, right? And then pain tolerance, how much can that person actually withstand or take? So if you think about it, if you're a soldier at war, you get captured and you're being tortured, they're going to test your pain threshold, right, somehow, to the level that they, hey, you know, as that soldier getting tortured, you're in pain, right? And then it is up to you as that soldier, right, to determine conditioned response, really, how much tolerance you can accept for the pain or with the pain. So elite groups such as the Navy SEALs, they do training in pain tolerance. So this is interesting. So pain tolerance is associated with activation of the C fibers, the limbic system, and the cortex. So a patient that reports excessive pain immediately after injury may be able to endure pain and continue to play at high level due to pain tolerance level. We've all seen athletes, I'm sure professional sports, go out there and play injured and play with stuff they probably shouldn't be playing with, right? Kurt Schilling and his bloody ankle back in the day for the Boston Red Sox is a classic example. He tears his peroneal sheath. The sheath is over your peroneal tendon is connected tissue that holds your tendon down and doesn't allow it to snap back and forth. It helps evert or turn your foot out. So essentially, he had a surgical procedure done to kind of reattach that so it wouldn't evert, so his tendon wouldn't pop up and down every time he threw. So when you pitch, your foot does kind of evert, and that's his push-off leg. So he had the surgery the day before, and he's having, pain like you wouldn't believe, but he's out there pitching. Battlefield conditions and pain tolerance. Past experiences on pain. So influences on pain perception, right? So past experiences is interesting here. There's a lot of research out in the sociological and psychological world, if you will, that discusses past experiences of a person growing up, and kind of ties in with the socio-cultural angle as well, that if you were, say, an abused child, your pain will be different than a non-abused child. So that's past experiences, socio-cultural, right? If you were raped, let's say, your past experiences, your socio-cultural backgrounds, even your expectations will change the way, right, you perceive that type of pain now. Not being raped again, I'm not saying that, but I mean by being injured in, musculoskeletal wise. And I bring up the rape thing because I think it's just an epidemic on college campuses now, and you'll see that in the news. My wife works at Williams College, the #1 school in the nation. If you look up Williams College, they beat out Harvard and Yale every year, top liberal arts college in the nation. But they average, I think, 29 rape cases a year. That's crazy. And she's an athletic trainer, and I know that she's had student athletes that have been raped. And how does that affect their pain and their perception, right? And you can see expectations of the pain. A lot of times when you hook up a therapeutic modality like an electrical stimulation unit on a patient for the first time, right, they don't know what to expect. They think it's going to hurt. And if they think it's going to hurt, it's going to hurt, right? Just like needles. If you walk in saying, oh, I'm going to give blood today, it's not going to hurt at all, it probably actually won't hurt. But if you have that fear and anxiety and you walk in saying, whoa, this is going to be like the worst thing since, I don't know, sliced bread. And it's going to be because you're influencing your perception on pain. Sociocultural does this as well. So sociocultural backgrounds. So there's some research out there that say if you come from a low-income, minority racial group, your perceptions on pain will be different than a non-minority social group and have higher influence, like have, greater amount of money or whatever it was growing up. Your perceptions will be different. Personality, definitely. Age and gender. Like I said before, males. Whoa. If we get sick, if a male, I know when I do this when I get sick. If I get sick, the world is coming to an end. If a female gets sick, if my wife gets sick, she continues going about her job. She's doing chores around the house. If I get sick, I'm not doing anything. I'm crying. I'm calling out for my wife. It's the truth, though. You can make fun of me, but male and female gender differences are there. Even as we age, it changes. Okay, this is a picture of the somatosensory tract, right? So this picture depicts from the spinal cord down here all the way up to the brain, right? And different levels of the brain and how we influence our mind and how we influence pain in our brain. We'll get there. So the somatosensory system is the body's sensory systems, right? It receives input from receptors in the periphery, the outside, and sends it to our hive centers in the brain. It's our warning system. You look before crossing the street, right? You know that there could be danger. Gunshots. Whoa. When I went to Old Dominion in Norfolk, right, Virginia, you'd hear gunshots quite often. ODU wasn't in the best neighborhood. You hear a gunshot and you get that conditioned response like, whoa, hold on, am I getting injured? Is there someone shooting at me? What's going on? These are basic mechanoreceptors that I'm sure you've actually seen and heard of in anatomy and physiology. So we have thermal receptors that detect skin temperature. We have Merkel's discs that are sensitive to low threshold mechanical pressure, and they slowly adapt to stimuli. Meissner's corpuscles, which are sensitive to low, same thing as Merkel's disc, but they rapidly adapt to constant pressure. Right? Piscian corpuscles, they're deeper in the skin. They react to higher levels of mechanical pressure. Ruffini corpuscles, they're located in subcutaneous tissues, organ, sensitive to stretching of skin, changes in joint position, and proprioception. So if I take a finger, right, and I'm bending it here, my Ruffini corpuscles know that my joint is changing joint position, right, and proprioception. Then we have the nociceptors, however you want to say it. These are activated by mechanical, thermal, and chemical antagonist agents, really, right? Yeah, this is a picture of the skin and where the Merkel's discs are, the Ruffini, the Meissners, all these things. I put this up here. I really don't need it. But I can draw. I'm learning. Here, pen. Ooh. Meissners, Piscinian, and then the Merkel's discs. All right. So, let's not go there. I don't want to confuse you. Nociceptors must be stimulated to initiate pain. 4 different mechanisms that can trigger this stimulation. Mechanical, thermal, chemical, and polymodal. Mechanical mechanisms, this is a direct force from an injury. So the pressure from the swelling, right? Thermal would be acute inflammatory response. Chemical does this as well, acute inflammatory response, but also something called capsaicin. So capsaicin is found in a lot of these creams, Bengay, Biofreeze, Icy Hot. Actually, capsaicin is a brand name in itself. And these creams help decrease the superficial pain receptors, their response, right? Essentially. So chemical is interesting here. And then polymodal is a combination of the 3, not necessarily including all 3, but it's a combination of them. Hyperalgesia. This is interesting. I actually have a patient with this. So peripheral nerves undergo sensitization that lowers the pain threshold after injury. Pain produced by normally non-painful stimuli is now painful. And we call that word allodynia, right? Allodynia. Pain produced by normally non-painful stimuli is now painful. I have a patient, so I work with our dance company a little bit on our campus. I'll treat patients and whatnot, probably 15 hours a week now. I have a patient who has had chronic knee pain, bilateral, right, both knees, patellar tendon pain for 4 years. She actually just graduated this past May, so she's had it. Has documented osteoarthritis. She's 21, 22. She's graduated. She got documented with osteoarthritic changes in her knees at 19, so her sophomore year, I believe that was. And some days she's very allodynic, if you will. So you can't even touch her knee without her jumping in pain. She can't wear jeans some days because the jean rubbing against her knee causes that allodynia response. She has to sleep on top of the sheets sometimes on her back because if she sleeps on her side or on underneath the covers or on her stomach underneath the covers, the sheets and the pressure causes her knee pain to get excruciating. I actually have tried many different things. This is probably one of the only patients, sounds bad, I haven't been able to really help. And yeah, it sucks. It's sad. We've tried so many different things and they'll help for a little bit, and then 2 weeks later she's back having pain again. So it's just one of those things that I'm not sure. All right. Yeah. Bradykinins. I talked about bradykinins last lecture. So inflammatory pain mediators. We have the mediator and the action. I put up these four because they're the most common inflammatory mediators that you see. Bradykinins directly stimulate nociceptors. Prostaglandin action is the sensitization of the nerve fibers, so other mediators can enhance nociception. Substance P is a neurotransmitter released centrally, right, to produce the pain response, and peripherally producing hyperalgesia and inflammatory responses. So substance P comes into play big time with gate control theory of pain. And histamine is released by mast cells to directly stimulate nociceptors. Histamine, right? Antihistamine. I'm allergic. I have allergies. I take an antihistamine, and most days it does do something. Not every day, though, right? Okay. Whew. Now we might get into some confusion. We have something called first-order neurons. So an action potential is generated, and it follows this path, the path of first-order neuron. It travels down the corresponding afferent, right? So afferent is coming towards the spinal cord, brain, central nervous system, right? It's traveling down the afferent nerve fiber to that receptor to be relayed to the dorsal horn of the spinal cord. So it goes from afferent, wherever this action potential is generated, let's say my finger, down my finger all the way to my spinal cord, to my dorsal horn of the spinal cord, and then it's sent to the corresponding area of the skin called the dermatome. So, dermatomes are areas of sensation within the skin. So, I'll turn them this way. C5 dermatome is roughly your deltoid here, teardrop. C6 is lateral forearm. C7 is essentially your middle finger. C8 is right here. T1 is up in the middle, medial humerus, I should say. And then you have T2 all the way down to T12 to follow your ribs. So if you have a spinal cord injury or neurological deficit going on, we can test the affected dermatome to see if they have deficits. Right? You'll do this in eval class. Whew, my great drawing that I got from some book that was probably older than both you and I. So let's say that this is going from our skin and our finger. It goes to efferently, right, to the dorsal horn of the spinal cord, back out, efferently, back to the tissue that it came from on the corresponding dermatome. A delta and C fibers are responsible for transmitting the pain. This is awesome because we can do this. We'll do this in lab, and then we can get rid of the pain. A delta is smaller in diameter. They're lightly myelinated, so myelination means they move a little faster, right? They transmit mechanical pressure or temperature extremes or ischemic pain. You have to Google ischemic pain. That's my homework for you right now. Google ischemic, and figure out what that is. These fibers are, remember, last lecture I said this, they're responsible for fast pain, either sharp or rapid pain. So this is the patient that comes in and says, oh, I have a sharp pain right here in my shoulder. It just happened a week ago, and it's very localized. It's a sharp, deep aching pain. That is my A delta fibers firing, causing that pain sensation. My C fibers are slower. And the bad part is there's a ton in the body. They're the most abundant in the body. They're small diameter and they're unmyelinated. And they're afferent, remember. Unmyelinated means they don't move very fast, right? Afferently, they're going from wherever to my central nervous system, brain, spinal cord. They respond, same thing, mechanical pressure, extreme temperatures, and chemicals. The crappy part about these is it is slow pain. Pain from these receptors from the C fibers are slow. Dull, non-localized, and diffuse pain. So this is the low back conundrum. You'll have so many patients come in and say they have low back pain. It's a dull ache. You can't centralize it. You can't determine if it's a disc or not. It's going down their leg maybe, but it's a diffuse kind of dull, achy pain. Those patients are the ones that are usually in the chronic inflammatory phase and they can't get out of it, right? You will see a lot of the C fiber pain. We can try to trick the brain's perception of their pain, though, by using therapeutic modalities. I always said trick and perception because when we use like an electrical modality, like a TENS unit, we are not actually physically changing the tissue. We're changing the central nervous system, the brain, spinal cord, perception of their pain, perception of that electricity coming into us, right? So that is a first order neuron. Bam, afferent, efferent back out. We have A delta, small, lightly myelinated. They do the sharp, rapid pain. Then we have the C fibers that do the slow, dull, non-localized pain. Whew. Second order neurons. Okay. Second order neurons are responsible for transmitting that stimuli up the spinal cord, to the higher centers in the brain. This takes place in the cerebral cortex typically. They cross the midline of the spinal cord to the specific ascending tract to the higher center, let's say the cerebral cortex. These higher centers, right, the second order neurons synapse or talk, right, communicate with higher order neurons through the thalamus, which is responsible for sending info to the higher centers, the amygdala and the cerebral cortex. We have something called a sensory homunculus. It's a great word, right? It's pretty funny, homunculus. It's an area in the brain responsible for processing sensory information throughout the body. It is directly related to the amount of sensory receptors at that site. So this picture, you can see, where's my mouse here? So you can see, the finger. I'm giving you guys the finger right now. The finger. It has a lot of nerve endings, right? Because it has a lot of touch, sensory receptors. Same thing with the face, the genitals, right? These areas have a lot of nerve endings and can be super sensitive, if you will. Areas that do not have a lot of nerve endings necessarily, intra-abdominal, the larynx, your teeth, gums, stuff like that that does not have a lot of nerve endings. So that's all a second order neuron really is. They do have specific tracks that you can actually map out based upon this type of issue. You can have a first or second order neuron up to the brain on this specific track that stimulates these specific neurotransmitters. That is not for this class. Trust me. Okay. Pain control theories. We have the primary and secondary pain control. Primary pain control is resolving the physiological pain triggers, so decreasing mechanical and or chemical irritation. Secondary pain control targets the transmission and perception of pain. So primary pain control, we're trying to decrease mechanical and or the chemical irritation. Right, so some over-the-counter, not, well, yeah, I guess some of these are over-the-counter now, but some prescription medications will target the chemical nature of the pain, right? Secondary pain control is what we do a lot of, right? We're trying to change the patient's perception of pain. The three main pain control theories we'll talk about right now are the gate control, endogenous opiate, and central biasing theories of pain. So the gate control theory, you may have heard of this before. Some A&P classes talk about it, not all of them do. It's really not that complicated, I don't think. Okay. You have increasing non-nociceptive input from the periphery into the spinal cord that can provide pain relief. Okay, let's take a baseball player getting hit by a pitch. They get hit by a pitch. Ow, my arm right here. I'm rubbing it. I'm getting hit by the baseball or softball. That is causing my nociceptive response, right? That's causing the pain, the baseball. By me rubbing it, I am increasing non-nociceptive, so non-painful input from the outside that provides the pain relief. So that's the simple version of a gate control theory. Receptors of A-beta fibers carrying non-painful stimulus can decrease the input of nociceptive stimuli from continuing to the second order neuron. So it does the first order, goes to the spinal cord and back out. It doesn't go to the higher brain centers, the amygdala, the cerebral cortex. This occurs within the dorsal horn of the spinal cord in an area called the substantia gelatinosa. SG, I abbreviate it sometimes, right? So substantia gelatinosa. So small diameter C and A delta fibers, afferent fibers, right? C, A delta, afferent fibers enter the dorsal horn and synapse talk directly, right, on the second order afferent neurons, the T cells, within the dorsal horn of the spinal cord. They inhibit this interneuron, so an interneuron only hangs out in the spinal cord, facilitates the spinal inhibitory interneuron, and that essentially closes the gate, if you will. So stimuli from these large myelinated A-beta fibers enter the dorsal horn, talk with the T cells and the interneurons, override that pain, closes the gate. The pain does not go up to my brain. Bam. I'm hit by a pitch. Baseball players are notorious for saying this. Oh, don't rub it. You're going to be a baby. Don't rub it. As you're walking to first base. Heck no. I'm going to be that baby. I'm going to rub my arm because that's going to decrease my pain. What idiot wants to stand there in pain? Right? Only I played baseball, so I can say that. Bam. I'm hit by a pitch. I'm rubbing it, walking to first base. As soon as I get hit, right, the nociceptive pain is out there. It's hurting. It's going to my body or to my spinal cord afferently. But as soon as I start rubbing, the A-beta, right, and these other, the A-beta fibers, are activated. They communicate with the T cell and the interneuron within the dorsal horn of the spinal cord, and it closes that gate. By me rubbing it, the A-beta overrides the C and A delta pain fibers, that closes the gate and doesn't allow it to go to my brain. So, recap. Small diameter C and A delta afferent are carrying the pain. A beta is carrying the good, right? Non-nociceptive. A delta and C are nociceptive. When it gets to that dorsal horn of the spinal cord, it closes that gate, cannot do a second order neuron. So it's essentially a first order neuron pain control theory. It has an effect in small diameter traffic. It takes place within the substantia gelatinosa, right, and the dorsal horn of the spinal cord. So those inner neurons can either open or close the gate depending on what they're receiving from the periphery. So if they're receiving more pain signals than less pain signals, it's going to open up the gate, and now it's going to create a second order neuron to my brain. But if we can override that pain sensation by either rubbing it, putting a TENS unit on the patient, etc., we can take away their pain. It's crazy. There's a lot of research out there that says when you as an AT, the first thing you should do when you go out on the field when a patient is injured is put a hand on them. Hey, are you okay? What hurts, right? Because by you just touching them, that stimulates this gate control theory a little bit. Not a ton, but it stimulates it. It can automatically, reflexively, right, relax them and decrease their pain. This is really not a good photo. It's from a book. I don't like this photo. Pretty much, it shouldn't transmit to the higher centers unless the nociceptive fibers override the good non-nociceptive fibers, right? If it's non-nociceptive, it's going to stay at the first order neuron. If it is all nociceptive and we're not doing the gate control, it's going to go up to the second order neuron, up to the central part of the brain, all right? So these large and small afferent nerve fibers interact. The larger diameter afferents are trying to inhibit or close the gate to the smaller traffic, preventing continuation of the signal to the T cell, while these smaller afferents are trying to keep the gate open to allow nociceptive impulses to continue. The tract with the most activity will prevail and be allowed up the spinal cord for the second order neuron. So pretty much the one that overrides, right, the one that has the most noise or action will win. And this is my baseball player example. Baseball player hit by a pitch, immediately nociceptive stimuli produced from mechanical force, baseball hitting you, and inflammatory mediators, bradykinin and histamine, all those, right? Initially, this is small diameter and are interpreted by the brain as pain. You begin to rub the area, adding mechanical or non-painful stimuli to the system is transmitted on the larger diameter, a beta afferent to the dorsal horn. If you begin to rub the area more intensely, the faster the rate of the larger diameter than the smaller diameter fibers, and the gate now closes, and bam, their pain will decrease. Now, will this be a long-lasting pain decrease? Probably not. It'll be more of an immediate pain relief. Enkephalon. Enkephalon has been linked in basic science labs to closing that gate. Enkephalon is released at the spinal level, having an inhibitory effect on the small diameter nerves. So if it's inhibiting the small diameter nerves, it helps close the gate. Clinically, the TENS unit. So TENS units are, they look like little cell phones, battery packs these days, and they stand for transcutaneous electrical neuromuscular stimulation. TENS units sounds way better than that, right? Can do that. Massage can do this. Whirlpools. Gentle range of motion can even do this. So if I sprain my ankle and I keep it not moving, bam, I'm going to have pain because the nociceptive fibers are going to override the non-nociceptive fibers, and the gate control theory won't work. But if we can gently move it and maybe do something else, that can decrease that patient's pain. In lab for this gate control theory, in my lab here in Mass, when I teach the therapeutic interventions course, we actually take a metal pipe, and I don't hit the students, but they hit each other. So one, we always pick a male. We can't hit females. We don't hit females. We pick a male, and we actually hit them with the pipe until they cry uncle. Essentially, they have 8 or 10 out of 10 on pain. They might get a little bruise from this. And then in the lab, we actually take different modalities, hook them up right away, and try to decrease their pain. Why? We're trying to show the students, at least I'm trying to show the student, one, what the pain feels like and what it feels like to be taken away. It's a little extreme. It's never that I have a patient or a student in there that actually has an injury right now that I can just use whatever they have. Nope. Never the case. Okay, so this descending pain control theory is based upon the gate control theory, but it's slightly different because it goes up to the higher center of the brain. That's essentially it. The gate it's an updated version of the gate control theory, except it goes up to the higher centers using a second order neuron. Endogenous opiate theory, right? The hypothalamus and the brain controls pain by prolonged, intense stimulation. This controls the release of these things called beta endorphins from the pituitary gland. Runners, distance runners, cyclists love beta endorphins. They get that runner's high. These are linked to actually enkephalon, but these enter the bloodstream and circulate. So a lot of patients that are runners will say, yeah, the first few miles it hurts, but after that, it actually feels good. I get a little high. That's why. The endogenous opiate is releasing literally like an opiate-based enkephalon from the pituitary gland that enter the bloodstream and inhibit the pain perception. Using different therapeutic modalities, we can actually do this as well. And the central biasing theory. So certain higher center brain structures can facilitate inhibition of the small diameter afferent traffic through descending connections in the dorsal horn. These are usually referred to as the central biasing, right? As central biasing. This usually occurs in the raphe nuclei, the cluster of nuclei found within the pons. Interesting. This binds to enkephalon, closing that gate and reducing the number of or amount of afferent traffic, therefore decreasing the pain. So enkephalon. Let's back up here. The central biasing theory and gate control theory are very similar. Serotonin, unfortunately or fortunately, is released often locally at the spinal level, inhibiting that second order neuron. Norepinephrine can also be released, and that has an inhibitory effect on pain transmission to the spinal level. So serotonin, norepinephrine, and enkephalon. Now enkephalon, gate control theory definitely, central biasing theory yes. Well, serotonin and norepinephrine are mainly talked about with the central biasing theory. You notice I'm kind of going fast through these other theories because the gate control theory is kind of the main theory out there right now. Common pain syndromes. Chronic pain. You will see patients with chronic pain. College and high school age patients, probably not as much as older patients, but pain response in the absence of actual tissue damage. So they may not have any tissue damage at all, but they have pain. Why is that? Well, pain actually becomes their pathology. How do you treat that? It takes a mental toll on their patients, their loved ones, their family members. And this can reflect an ongoing disease that continually activates nociceptors, such as arthritis. So how do we stop the underlying inflammatory process? Chronic pain characteristics. So patients that are diagnosed with chronic pain, symptoms last longer than six months, half a year. They have few objective medical findings. They have x-rays and all these other things, and nothing is showing up. They may abuse medication, either over-the-counter or prescription medicine, which you see a lot now, the opiate prescription pain pills. Difficulty sleeping, depression, manipulative behavior, and somatic preoccupation. What is this? Another homework assignment. Google somatic preoccupation. It's crazy. Ask yourself this too. If you've had pain symptoms lasting longer than 6 months, you probably would be depressed. You're probably not sleeping well, which may actually lead into medication abuse or manipulative behavior to get that medication. You might be lying to people. You don't want to go to work because you're depressed, or school because you're, depressed, not sleeping. All these tie into each other. You can't just have one. It's like the potato chip, Lay's. You can't just eat one chip. Trust me. I see a lot of chronic pain patients with the dance population. Is interesting because they don't like telling people when they're hurt because they want to keep dancing. So they could have had an injury from, age 6 and now they're in college or 18, 19 years old. And they've had chronic maladaptations or dysfunction for years. And now they have pain everywhere. It's interesting. We have this referred pain. This can occur from either visceral organs or an orthopedic. Not the basis of this course, though. You'll do this a lot with eval classes. 2 I'll talk about real quick. McBurney's point is your appendix. So you find your belly button, you find your ASIS, your hip, all right, anterior superior iliac spine, and the dead center of that on your right side is your appendix, called McBurney's point. And then you also have Kerr's sign. When you have a ruptured spleen or splenic injury, you have left shoulder pain. That is an example of referred pain from visceral organs. Can occur after orthopedic or soft tissue injury as well. So you have injury, let's say, to the C6 dorsal root. You could lose sensation to 3 different nerves that go down your arm. Radial nerve, median nerve, ulnar nerve. Again, not the basis of this course. I talked about myofascial pain a little bit last lecture. It's not well understood yet. Anatomy Trends, like I said, is a great book. You have a couple different things here. You have trigger points and tender points. So a tender point is when you push into the muscle, it hurts, but it doesn't cause pain anywhere else. A trigger point would be you push into that muscle, you find a knot, if you will, and it's giving you a headache when you push in that knot. That is a trigger point. I love positional release therapy, PRT. We will learn PRT later in the summer. We will do it hands-on. We will take away some headaches with it. We will make everyone even again. It's very similar to something called strain counter-strain. Back in the day, I used to go digging in. So if I had a knot on my neck, back here, I would take my thumb in that patient's neck and dig as hard as I could to get them out. Well, new literature says that's not productive. We'll discuss that later when we talk about PRT. What about the placebo effect? Pain is sometimes indirectly decreased due to the placebo effect. Patient actually isn't getting treatments but feels better afterwards. You see this all the time with prescription medicines, and they're doing a randomized controlled trial, and neither the researcher or the patient knows if they got the medication, but yet they feel better or have improvements because they think they're getting it, right? Ultrasound with the wand, right? I've done ultrasound on patients. Set the machine up like 7 minutes, all this, and I forgot to turn up the intensity. So pretty much I rubbed a wand on them for 7 minutes and didn't have the machine on at all and said, oops. But I don't tell them that because they perceive it's working. You can ask them and say, yep, did this feel better? Yep, awesome. I'm going to go play my game now. All right, good. And Johnny goes out and plays his game. Well, that is the placebo effect. We see that a lot these days. I'm not saying not to turn on the ultrasound either. Just when you get busy, you will forget. I've honestly forgot to turn on the timer before. They're just going for, I'm rubbing the ultrasound machine on. It's 20 minutes later. What the hell is going on? All right. So we talked about this already in the first lecture. We're skipping that. We know what therapeutic modalities is. Medications, NSAIDs, I spoke about last lecture too. Non-steroidal anti-inflammatory drugs, most common pain control. right? They block the action of prostaglandin. Acetaminophen decreases the pain but has low effect on inflammation. You have local anesthetics that you can get injections with. Even opioid analgesics. These are your prescription pain medications. These are highly addictive, like Percocet, morphine. Everywhere in the country these days, there's an opioid addiction going on, unfortunately. So again, how do we measure pain? Well, when we measure it, it should encompass sensory information, cognitive information, and the behavioral interference between that. So this disability of the physically active scale, the DPA scale, does this. So I actually don't have this open right now. DPA scale, I'll search for it. The disablement and the physically active scale. It is a scale that is out there in the literature that actually helps decrease pain, or not decrease pain, assess pain. It's a great article. It's free text right here. You can download it. It's by Vela. There's 2 of them. Part 2 actually has a scale, and it's a outcome measure that we can actually assess to decrease, see if we're actually helping that patient's pain or not. Other reporting measures, patient or pain is a personal experience, and that patient self-reported measures are most meaningful. We have something called the visual analog scale and the numeric pain rating scale. The visual analog scale, I actually don't really use this ever. Is either a horizontal or vertical line that's usually 10 centimeters in length. There's no, the verbal descriptors are no pain and worst pain imaginable up there, but there's nothing else in between. And then you kind of mark where you are on the line here, and it's scored on a 0 to 10 or 0 to 100 scale. I think it's very subjective. I really don't care for the VAS. I do like the numeric pain rating scale, NPRS or NPR. I do actually like NPR too. So it's a 0 to 10 scale to tell me your pain. 0 is no pain. 10, take me to the emergency department now. It's a very reliable method. Say a patient walks in today with an ankle sprain. They have a 10 out of 10 of pain. I want to decrease their pain by at least 2 points or 33%. And that tells me that I have had an MCID, statistically speaking, a minimally clinical or clinically important difference. Right? Minimally clinically important difference. That patient walks in with an ankle sprain, 10 out of 10. I want to decrease their pain to at least an 8 out of 10, because if I don't, that patient will have no perception that I changed their pain. If ideally I take it to 0, if I take it to like a 2 out of 10, whoa, that patient changed 8 points. That is hugely clinically important. What did I do to decrease their pain by 8 points? Did I do one thing? Did I do 2 things? Did I throw the whole kitchen sink at them? Well, here's a lesson. Don't do everything that you know how to do at once. Why? You will have no idea what helped that patient. Do 1, 2, maybe 3 things and see what helps them the most. Whew, quick lecture. Pain and pain perception are not well understood yet. The way we decrease pain is, again, not well understood yet. Look at this last bullet point. This is a take-home message. On average, 17 years from when a research study is conducted and published to actual use in a clinical setting. 17 years ago. So stuff they were doing back for research in 1999 and 2000 is just coming out and actually being used in clinical practice this year. That's freaking ridiculous. That's nuts. Why is that? But it's true. We'll talk more about that throughout the semester. For now, that is all for the first week. So pain actually is the beginning of your second week of lecture as well. So we'll discuss this a little bit more, but I'll put up another video to make sure that you guys do your quizzes and do the discussion board. Have a good weekend.